recording it.
There you go.
Okay, great. My name is Bill Lorman. I'll introduce myself and then we'll let Tim introduce himself. I am a psychoanalyst. I'm also a psychiatric nurse practitioner. I have specialties in addiction, and I have worked in the addiction field for 22 years, both inpatient and outpatient. And so over the years, I have done multiple national and international speaking engagements on addictions and different issues with addiction. So, and I'm also on faculty at IMPP, in which both Tim and I will be instructing a course on addictions, a much more flavored psychoanalytic course on addictions. So that's my spiel. The other thing that I just want to bring up before I let Tim give a little background on himself is please mute your computers so there's no interruptions. And if you have questions, Lisa, should we have people type them into the text box or what?
Yeah, sure, absolutely.
Okay, so you can type your questions in, and then we'll answer them at the end. Usually people have questions as we're doing our presentations, and more times than not, they're answered in the body of the presentation. So that's why we ask that we hold off until the end. So Tim, you're up.
Okay, fantastic. Thank you. I'm Timothy Legg. I am a student actually at PSP. I've been here for 5 years. Prior to here, I was a student at CCMPS. Aside from my student role, I am a licensed psychologist and a psychiatric mental health nurse practitioner. I've I've been working in addictions well over 20 years, and my practice has evolved such that a significant number of my patients, well over 50%, have some type of addictive disorder that they've been struggling with. Very happy to be here and was frankly quite honored when Dr. Lorman had asked me to participate in this. So thank you. Thank you all for coming.
Okay. So with that, I am going to, we're generally going to use a PowerPoint presentation, which hopefully everybody can see, right? And if for some reason the thumbnails of pictures of yourselves are blocking the PowerPoint, you can let me just what did I do? There we go. You can minimize that. So hopefully everybody can see that slide. If you can't see it, speak up. Otherwise, we will get moving. Okay, so here's our objectives. For some reason, I have some sort of a yellow box. I don't know if people can see that on the right. Tim, can you see that yellow box that's covering the slides?
I
There,
can't.
it disappeared. All right.
Oh, okay.
All right. Now it's all right. So there's our objectives. There, hopefully we'll be able to cover that and probably a lot more on what we'll be talking about. So I'm going to start the presentation talking more about the brain and addiction. And this presentation is heavy on contemporary addictionology, on neuroscience, on some basic techniques and that type of thing. We do have a section related to psychoanalysis towards the end, but we're actually saving all of our psychoanalytic mumbo jumbo for our course that we're holding in September, because there's just so much information and such a large history on the psychoanalytic treatment and addictions that we didn't want to really get into all kinds of other issues. So basically, this is kind of a primer for what's going on in the brain, what we now know currently about what's happening, and some basic techniques and treatment models that we can talk about. So I've taken these slides from Stephen Stahl, and to me this is the theory that best explains what's going on in the brain. And that it's unfortunate that when I put the slide in, the part of the rest of the brain is in a very, very dull white, and it's really, really hard to see. And all you can see is what's referred to as the mesolimbic pathway that originates in the lower left there at the ventral tegmental area, and then through a bundle of neurons ends in the nucleus accumbens. And basically, every drug of abuse finds its way to the VTA, to the ventral tegmental area. As a matter of fact, that's how the feds, the DEA, the FDA, have determined when a particular substance is an addictive substance, is if they find it in that area, if it ends up there in the ventral tegmental area. An interesting story is the drug Lyrica, when it came out, was supposed to be for anxiety and pain, and it was supposed to be non-addictive, and everybody in addictions was cheering that there was a new medication coming out that was a lot stronger than Motrin and a lot better than any anxiolytic that we have. And so at the 11th hour, before it was to be launched, the FDA found that Lyrica did in fact show up at the ventral tegmental area, ultimately stimulating the nucleus accumbens, which is the pleasure center of the brain, and therefore it became a controlled substance at the last minute. So that was a bummer. Even though it was only Schedule 5, it's still a controlled substance, and people can become addicted to it. So anyway, that mesolimbic pathway is stimulated every time we do anything or engage in anything that produces happiness, contentment, satisfaction. So our internal neurotransmitters find their way to the ventral tegmental area, stimulate the nucleus accumbens, and we are happy. All right. Now that is directly opposite of what the original theory of happiness and contentment is. The original theory was we first become happy, and then the VTA, the ventral tegmental area, gets stimulated. We now know it's the exact opposite. Before we can experience happiness, contentment, satisfaction, we have to release chemicals into the ventral tegmental area, which then hits the nucleus accumbens, right? So that's the good news. But the bad news is that the drugs of abuse do the exact same thing. They all reach the ventral tegmental area, but from 10 to 100 times stronger than our most satisfying or happy moments that we are able to experience, right? And so what happens when somebody begins using drugs of abuse, they want to replicate that level of euphoria that's created. And so the beginnings of addiction occur. And so these are the drug categories. They are determined by the feds, by the way. This is the list. They're the ones that add to it. And what has happened lately is it's become very, very vague. So you can see at the bottom, they've added synthetic, over-the-counter, and club drugs, which in and of themselves fall into other areas or other categories of drugs. And so generally, we're most familiar with the top handful of categories. But for instance, ecstasy chemically looks like a central nervous system stimulant, but behaviorally, it's an hallucinogen. So people didn't know where to put that drug, how to list it, specifically on death certificates. So, that even today has become a problem in how to list causes of death or even specific diagnoses, because a lot of these newer club drugs, synthetic drugs, and even some of the over-the-counter that aren't showing up in drug screens, we have no way of identifying them or labeling them as such. So that in itself has become a chronic problem in our business and proper documentation. Okay, so this is what I've done here is I've taken these like Lego toy things and created what the chemical structures. I've only listed 4 here: nicotine, alcohol, heroin, and cocaine. And as you can see, each drug, and this goes for the whole plethora of drugs of abuse, they all look significantly different from one another. And so the biochemists knew the chemical structure before addictionologists and neuroscientists understood how they worked in the brain. And so the biochemists concluded, since these drugs all look so different, they must all hit a different area of the brain. And that was the going theory for a while. But now, as I previously said, all of these drugs end up at the ventral tegmental area, no matter what size they are or what category of drug they all end up there. And so, to answer the question, is there a single pathway to addiction? The answer is yes, there is. Because initially they all produce acute reward, and then there's chronic reward as positives to the use of the drug. There's sensitization of the receptors, which in itself creates the problem of death when somebody becomes abstinent and then decides to relapse after a short period of abstinence, and they begin using the same amount of drug. In the meantime, the receptors have become highly sensitized, and what happens is the drug that originally gave them the level of euphoria actually kills them. For the most part, we have negative withdrawal symptoms. There are some drugs of abuse that do not carry with them a withdrawal syndrome. Associative cue learning refers mainly to people, places, and things. So things other than the actual use of the drug can cause craving. So that's the new term for craving, associative cue learning. And then we have relapse, which is an old term. And so the addictionologists have created a new term that sounds a little more classy. Incentive motivation is the new term for relapse. And what happens in the progression of addiction is we go from impulsivity to compulsivity of use in the way that we describe the progression of addiction. And so this, again, is another slide that I've taken from Stephen Stahl's Essential Psychopharmacology. And this is just an enlargement of, to the left with what looks like an octopus, is the ventral tegmental area with all of its different spikes coming out. And then the neuron, the neuronal projection, and then it ends on the right with the nucleus accumbens. Okay, and that little butterfly-looking thing in there is actually a graphic for dopamine, is what that is. And this particular graphic very nicely explains the whole theoretical premise of the single pathway and how all the drugs of abuse end up here and how they stimulate receptors in the VTA and cause euphoria. So let's start with alcohol. Alcohol uses the GABA system. And so the brain, when alcohol is taken in and alcohol molecules migrate to the brain and find their way to the ventral tegmental area, the brain identifies alcohol as GABA, as a GABA neurotransmitter molecule. And so it hits the GABA receptor. So alcohol hits the GABA receptor, in which the stimulus occurs, goes down the neuron, and releases dopamine here, which hits receptors in the nucleus accumbens and causes euphoria. So that's how alcohol causes euphoria. Cannabis hits the cannabinoid receptors. The opioids hit the mu opiate receptors on the VTA. It goes through the exact same process in stimulating those receptors that cause the ultimate release of dopamine at the end of the neuron, and the dopamine hits the nucleus accumbens, and the person experiences euphoria. Same thing with nicotine. And nicotine is a funny drug. Nicotine, the brain sees nicotine as acetylcholine, oddly enough. And so when nicotine reaches the VTA, it hits the acetylcholine receptors, which do the same thing, releases dopamine and causes the feeling of calmness, actually. We don't generally use the term euphoria when we're talking about nicotine use, but there is a feeling associated with that, with the release of dopamine. And I'll talk about the nicotine in just a second. The hallucinogens, when they reach the brain, hit the serotonin or 5-HT receptors. So the brain views all hallucinogens as serotonin. And in the ventral tegmental area, they hit the specialized serotonin receptors, which again do the same thing. And then we have PCP and also alcohol again hitting glutamate, causing the release of dopamine. And if you'll notice, cocaine isn't mentioned. Well, cocaine and crack is special in a special way. The cocaine and the amphetamines bypass the ventral tegmental area, go directly to the end spot here, and chemically rip out dopamine, so that cocaine, and specifically crack, by definition, because it's able to bypass the whole system, go right to the end point here, release huge amounts of dopamine inventories, causing very, very high euphoria. And so crack cocaine, believe it or not, is the most addictive drug because it works so fast and releases so much dopamine from the VTA and the corresponding neuronal branches here. The other important thing to relate to you is the prescribed psychostimulants like Ritalin and the amphetamines act just like cocaine. They work the exact same way, and they bypass the whole system here, go right to the end point, cause the release of dopamine by chemically reaching in and causing dopamine to be released and hitting this area. Now, it's not this particular action that resolves ADHD. The other thing that cocaine and the amphetamines do is they also hit the norepinephrine and epinephrine system in the brain. And it's the norepinephrine increase that creates increased focus and concentration, not so much the dopamine. The dopamine does a little bit with that, but the psychostimulants really work on the norepinephrine system. Now, getting back to nicotine, the thing that I want to point out that people in general don't worry so much about nicotine is because a very interesting fact about nicotine is when it hits the acetylcholine receptor, the acetylcholine receptors over time desensitize, right? All the other receptors around the VTA do not. So the more drugs that hit those receptors, the more stimulation occurs. Not true with nicotine. The acetylcholine receptors very quickly desensitize. So no matter how much the person smokes, the nicotine receptors are not doing anything. And so 95% of the population that smoke, their nicotine receptors desensitize. And it takes anywhere from 2 to 4 hours for those same receptors to resensitize. And for those people in that 95% of the population, you know exactly when those receptors are resensitized, because those folks, those smokers generally have a cigarette when they get up. They go to work. In a couple hours, they have to take a cigarette break before lunch. They take a cigarette break after lunch. They take a cigarette break later in lunch, depending, and it all is related to when the cravings start as a result of the desensitization of the acetylcholine receptors, right? Now, that's 95% of the population. 5% of the population, the acetylcholine receptors do not desensitize. They stay sensitized like all the other receptors. They're the folks that we call the chain smokers, right? So 5% of the smokers in the world have acetylcholine receptors that do not desensitize, right? And they just smoke one cigarette after another because it causes stimulation in the nucleus accumbens. And another important fact to remember, and I have some slides coming up, is the fact that if we don't have a receptor for a particular substance, it doesn't affect us. So for instance, you could snort all of the catnip you wanted, and it would have no effect on you because we don't have a receptor for catnip in our brain. And only 85% of cats do, right? So only 85% of the cat population have a receptor for catnip, and that's why they react the way they do. And the other 15% of the cat population, they have no receptor for catnip, so it does absolutely nothing for them. So that's another one of those important things as drugs are being created, drug manufacturers, these guys on the street, these, highfalutin chemists, street chemists, they're experimenting with all kinds of chemicals. And obviously, if a chemical is taken into the body and it has no effect, then they know there's no receptor for it. Whereas if they, in fact, have a receptor, the drug will have an effect. Okay, so just based on what I said, the brain does, in fact, make its own morphine. It's called beta endorphin, by the way, and it makes its own marijuana called amantadine, amandamide, I'm sorry. And that's why those drugs can hit the receptors in the brain, because the internal chemicals have a receptor. They even make their own antidepressants, anxiolytics, and hallucinogens. People say, oh, hallucinogens, how do we make our own hallucinogens? That's really the neurochemical for creativity. So we all know if you close your eyes and I say, imagine your living room, you're able to do that. And a lot of people can even imagine it in color. Well, that's the result of the internal hallucinogens that create that. Children are very, very good at having a large amount of internal hallucinogens. They have imaginary friends. They have a very strong fantasy world. People that are highly creative today, adults, architects, interior designers, all of that, they have a strong hallucinogenic internal system, right? So these drugs that are taken into the body will mimic the brain's natural neurotransmitters. That's how they work. And the drugs are generally discovered prior to anybody figuring out how exactly they work. So we knew about morphine before we knew about beta endorphin. We knew about marijuana before the discovery of the cannabinoid receptors. We knew about Valium and Xanax before we knew about the benzo receptors in the brain, the GABA receptors. And we knew about Elavil and Prozac and all the other SSRIs before the discovery of the serotonin transporter site. So these drugs are all created before we really understand exactly how they work in the brain. You know, I was lucky when I went to undergraduate program, excuse me, and I took my pharmacology course because um, when we had to know the name of the drug and its therapeutic effect, but as far as mode of action or mechanism of action, it was always unknown. People didn't know how these drugs work. Even to this day, we're not positive how aspirin works. We know some of it and how it opens sodium channels and it does a few other things, but there's plenty of things that aspirin does in the brain that we have no clue how it works and why it does some of the things that it does. So that's another important fact with the drugs that are being created. For the most part, there's guesses as to the mechanism of action until they can actually figure that out. Okay, so now we're getting into the transition of addiction, and this part's going to go pretty fast. Basically, everybody believes that taking drugs begins as a voluntary choice in order to seek a pleasant stimulus or for the experimenter to determine whether a pleasant stimulus actually exists. But for addicts, the choice is no longer volitional. This is where it gets a little hairy because there still are a lot of people out there that don't believe that once addiction occurs, that the person is unable to easily stop, even in the face of terrible personal consequences. And basically what I talk about is cravings. We all know what cravings are. We all experience cravings, but the cravings that we experience are what are known as psychological cravings. So for instance, I crave chocolate, but I don't have to go into the Badlands of Philadelphia when I crave a chocolate bar and drive down at 2 o'clock in the morning to find a place that I can get it, right? We can hold off until whatever. So when I get done this presentation tonight, I may have a Hershey bar. I can put off doing that. So there's psychological cravings. We all have them. Ice cream, sweets, that type of thing. But in addiction, they have what are called physiologic cravings, not psychologic cravings. So psychologic cravings create a good feeling. Oh, I can't wait to get my hands on a chocolate bar. I'm really going to enjoy that, or whatever it happens to be, right? Physiological cravings are the exact opposite. Physiologic cravings are painful. I tell people it's like a migraine or an abscessed tooth. And the person that has a physiologic craving knows that the only way to get rid of that craving is to use the drug that they were using. The only way, right? That's a big part of the withdrawal process, the physiological craving that the person goes through, and it's painful. So this slide just talks about the initial stages of addiction, and as exposure occurs, we get the mechanism of dependence, which the DSM has taken out. They have taken that word out of the DSM. Now they use substance use disorder rather than dependence. And so prolonged use of the drug leads to more long-lasting changes in the brain. So not only does the drug continue to cause euphoria, but ultimately it does cause physical changes in the brain, causing what ends up to be an addictive situation. So we have what's referred to as the two-hit hypothesis in psychiatric disorders, which is similar to personality development as we know it psychoanalytically. And so the two-hit hypothesis psychiatric disorder, which is more formally known in psychologic circles as the stress diathesis model, if you've heard that. And basically, and this is what's accepted most in psychoanalytic thought, we talk about nature and nurture. So that, again, is what this is. And so what this hypothesis states is in order to manifest an overt psychiatric disorder, one must not only sustain the first hit, which is the critical genetic vulnerability. So we have to have internally the nature, as we would say psychoanalytically, the gene modification in there, and we must also sustain the second hit, which is some type from the environment. That's the nurture. Personality development follows the same rule, nature and nurture. So personality is made up of temperament, we now believe, which is genetic, and character, which is environmental. So those two categories or elements, temperament and character, is what produces personality in each of us. And so that basically follows the two-hit hypothesis also. And so cravings, this is just one of those technical slides. There are two types of cravings, cue-based and state or stress-based. And cue-based respond to environmental use. They create an internal state, which is recognized as craving, which is people, places, and things, as AA talks about. And it's most notable in people that are addicted to cocaine and nicotine, right? And state or stress-based craving has to do with emotional tone, level of perceived stress, the state of self-care, and that's what sets the state. And it appears, these cravings appear out of difficult emotional states. So this is more internal, and it's found most notable in alcohol and sedative abuse, or use or misuse. And if you notice, what's missing are the opiates, and the opiates have both cue-based and state-based craving periods. So that's a double whammy. So I'm going to very, very quickly go over what the DSM-5 says about substance use disorder. The DSM-4 and before that used the term dependence. DSM-5 has stopped that. We're not allowed to use that. It's considered a pejorative word. So we're supposed to use substance use disorder. And so the initial statement is it's a problematic pattern of substance use leading to clinically significant impairment or distress and manifested by at least 2 of 11 criteria occurring in the same 12-month period. Now, this is different from what DSM-4 and before said. First of all, DSM-4 characterized dependence as a maladaptive pattern of substance use. And everybody said, what does that word mean, maladaptive? We don't understand that. And the DSM fathers said, that's up to you. You have to determine what maladaptive means. We don't tell you that. And so everybody complained about that. So when the DSM was revised, DSM-5 took the word maladaptive out and put in the word problematic. And so once again, we say, well, what is the boundary for problematic? And the DSM people said, well, that's up to you to figure out. So we're right back where we started. And it's vague, and each individual clinician has to make their own determination of what determines problematic use. All right. The other change is DSM-5 or DSM-4 had criteria, 3 out of 7 criteria. DSM-5 says you only need 2, and they're giving you 11 choices to make. You only have to meet 2 of those, which you'll find are very, very easy. Okay, so here's the essential features, what they are. Basically, I'm going right to the second paragraph, an underlying change in brain circuits that persist beyond detoxification, which is another term that they've taken out. We're not supposed to use that, but everybody still does use that. We're supposed to use withdrawal management now is the new term, because detoxification has been branded as ambiguous, because the public health term means to take away toxins. And during addictive detoxification, we give people toxins in order to help and then begin weaning them from those. And we call that detoxification. So they've taken that term out, and now it's called withdrawal management. But as I said, nobody really has picked up on that yet. Okay, so criteria are put in certain categories of what are called pathological patterns, and patterns of impaired control, social impairment, risky use, and pharmacological criteria. So both the DSM-4 and the DSM-5 still carry these patterns of behavior. And so under impaired control, we have the first one, the substance is often taken in larger amounts over a longer period than was intended. Most people that I treat will say, yes, this is true. Number two, a persistent desire or unsuccessful effort to cut down or control use. Again, I'll ask people, have you ever tried to stop? All the time. They tell me it just doesn't work. And then number three, a great deal of time is spent in activities necessary to obtain, use, and recover from the effects. Now, here's another one of those interesting major changes that the DSM-5 made. DSM-4 and before used this particular criterion. A great amount of time is spent in finding the drug, using the drug, and then withdrawing from the drug, recovering from the effects. That used to be called criterion number 5 in the old DSMs. And that's how we determined severity. Basically, we said the more time that was spent in those activities, the more severe the addiction was. DSM-5 has changed the rule. They're saying severity is based solely on the number of criteria that the person meets. That's how they're saying the severity of the addictive syndrome is. How many actual criteria does the person meet? And number 4, they've added craving or a strong desire or urge to use as a new criterion that has been determined to play. And here we're talking about physiologic craving for that. And then social impairment, we have recurrent use resulting in a failure to fulfill major roles and continue use despite having persistent problems. And then social, occupational, recreational activities are given up. I don't need to go over that. And of course, risky use, we've taken from the old criteria that were under abuse. Recurrent use in situations in which it is physically hazardous. So a person that is using and driving a school bus or using heavy construction equipment would meet that criteria. And use continued despite knowledge of having a persistent or recurrent physical or psychological problem. Again, people know this. Basically, what number 9 says is the person knows it's bad for me, but I do it anyway. Don't all cigarette smokers say that? I know it's bad for me, but I do it anyway because I enjoy it. And I don't think it's that bad. So they have denial, right? Okay. And then the pharmacological criteria are tolerance and withdrawal, which there are some the hallucinogens do not have a tolerance or a withdrawal syndrome associated with them, but all the other ones do. Okay, and then I'm going to end with pseudo addiction here. Basically, this is something that you also need to understand when you're working with patients. Symptoms of tolerance and withdrawal occurring during appropriate medical treatment with prescribed medications. So, for instance, if somebody's in or breaks their leg, let's say, and they have to set it and all that kind of stuff and put pins in, and they give them a prescription for, let's say, OxyContin, and send them home with a prescription for a month worth of OxyContin. And basically they say, when you're done, that's it, use Motrin, right? But what they don't understand is the rule for withdrawal is if you're taking a controlled substance consistently for a minimum of a month and you stop cold turkey, you're going to have a withdrawal symptom. And people think, and the same thing happens with, say, Xanax. If somebody is given Xanax and the prescription isn't renewed or they're not weaned off of it, and they stop after a month, they're going to have a withdrawal syndrome when they stop, right? And people think because they're in withdrawal, they're addicted. They are not. That's called pseudo addiction. And we also have it with symptoms related to under medication. So people, for instance, that are addicted to heroin, that are in a car accident and go into the hospital and are ordered one lousy Percocet every 4 to 6 hours for pain, that's not going to touch them because they're used to taking 400 milligrams of OxyContin, every couple hours. So a single dose of Percocet or 2 Percocets aren't going to touch their pain. And so people that are administering those meds are going to say, oh, they have an addiction. We got to not give them that. Don't give them any opioids, give them Motrin. And that is called pseudo addiction. And those people really do need a higher dose of medication. And so now I'm going to turn it over to Tim, who's going to talk about some statistics and some problems related to costs and implications.
Fantastic. Thank you, Bill. So before I get into statistics, there are a few things I want to point out. Uh, whenever we talk about statistics, we know that there are always, and you're probably calling back from your graduate school days when you had to take research, there are always problems with sampling. So depending on the source of the statistic, depending on the article that you're reading, you might see different numbers, et cetera. But before I delve into some of these numbers, I like to remind everybody that when we talk about statistics, they're nothing more than people with the tears wiped away. So I'm right now I'm calling on data that was compiled in 2023 from the United States National Survey on Drug Use and Health. And this is actually a survey that is completed annually. The most recent one available for me was 2023. Hopefully they will continue it. But based on that national data set, it was reported that approximately 16.7% of Americans, and they look specifically at those age 12 and older, had some type of a substance use disorder within the preceding 12 months. And well, what is 16.7%? Roughly 48.5 million people, actually. 10.2% of Americans had an alcohol use disorder in that time frame, and about 27.2 million Americans had a drug use disorder, and about 2.7% of the population, approximately 7.5 million people, struggled with both alcohol and drug use simultaneously. When we were waiting for the presentation to begin, I pointed out that we're not just dealing with an epidemic. I'm calling it pandemic. This is getting the statistics on substance use disorders in the United States are becoming quite concerning. If we can go to the next slide, please. In this slide, this was a 2025 publication from the National Institute on Drug Abuse. And basically what they looked at was the number of overdose deaths from various substances from 2000 to 2022. Of course, each line representing different color, each colored line representing a different substance, ranging from prescription opioids, heroin, fentanyl, cocaine, methamphetamine, etc. And what we do see is a disturbing trend, obviously upwards, but around about 2014, we see where fentanyl really does take off, exceeding all of the other substances of abuse. So, frankly, multiple substances are becoming problematic. We could see from about 2013 onward where methamphetamine is experiencing a rather significant peak, as is cocaine. So again, on a whole, they've all increased, some more rapidly than others. If we could go to the next slide, please. Why use substances? This is something that disturbs, and I'm positive that anybody here who has ever worked with anybody who struggled with an addictive disorder, you may have heard this from, family members or even perhaps the patient themselves. I don't understand why I did it. I don't understand why my husband does it, my brother, my sister, my child, etc. And the reasons for this are we could have an entire 2-hour seminar on this. Uh, the reasons are multiple, perhaps to explore something forbidden. And I'm going to come back to this in a few more slides. Some people do discover that substances, through the activation of the aforementioned pathways that Bill described to us, can alter existing negative states. I have met many patients over the years who basically have told me, yes, when I drink, I'm no longer depressed. When I drink, I am able to cope with various anxieties. When I use fill in the blank with the substance, I'm able to do something that I otherwise couldn't do. This phenomenon is what led Canadian physician Gabor Mate refer to drugs as the social lubricant. So again, some people, we see this with hallucinogens particularly as well. They might want to experience something outside of their daily lives, something outside of the ordinary. So the reasons why people use substances can be quite varied. Next slide, please. So the original question that the original top bullet point, why do people use substances? Yes, there can be a reward potential. We have a much better understanding today of the underlying physiology. And if something feels good, there is typically a tendency to want to continue that, to want to continue to experience that. Uh, Social learning, that has a role in substance use disorders as well. Persons may be misinformed, and you see this often in early experimenters. Oh, well, it can't be that bad. Your father is smoking, your mom smokes. Well, what's the big deal? Let's try it. Additionally, individuals may have expectations about the substance that they are about to use, how it's going to make you feel, how it may not make you feel, what it can prevent you from feeling, things like that. We also were talking when we were waiting for the seminar to begin tonight about the various cultural and social influences. And yes, cultural and social factors have a very powerful impact on individuals' decisions to use substances. So again, this is something we could do a whole other 2-hour lecture on. And in terms of legal sanctions, these also can do occur. Many of you may work with individuals who are justice involved as a result of substance use disorders. But in many cases, you're going to find that individuals may be reluctant to give up substances. However, they seek out treatment because of the legal sanctions that they have experienced as a result of their substance use disorder. If we can pop off to the next slide, we're going to talk very briefly about process addictions. And it's beyond the full scope of our discussion tonight, but the DSM does recognize non-substance related disorders, specifically gambling disorder. And there are a variety of non-DSM 5 text revision disorders that many individuals assert are disorders, and food addiction. And I'm not referring to binge eating disorder, which is recognized by the DSM, but some people will, and many times people will flippantly say, well, I'm addicted to that, when in fact, no, they don't actually meet the criteria for a substance use disorder. But they may say, oh, I'm addicted to, fill in the blank, diet soda, pizza, Doritos, chocolate bars. Um, Sexual addiction, that is something there's a great deal of controversy in the literature. Uh, Many times I've met individuals who allege that they were diagnosed with sexual addiction only to find out that their sexual behaviors were discordant with their partners. So again, is it an addiction? Isn't it? DSM-5 does not recognize it, but many sources do. Internet addiction, and we've certainly all met the person who cannot put their phone down even through a meal. Work addiction, and then of course the adrenaline, the so-called adrenaline junkies, persons that engage in some very high risk types of behaviors, play, etc., which can have potentially negative consequences, loss of life or limb, but they enjoy doing it anyway. And then, of course, the infamous shopping addiction. So again, many times people will refer to things as addictions that may or may not be. And again, I want to point out, I have no vested interest in that or skin in that one way or the other. Instead say that the future will tell us if these truly are addictive disorders or not. Next slide, please. There are challenges to the identification of addictive disorders, and hopefully I've alluded to that in my previous slide. And for reasons that Bill had talked about a little bit earlier, what is an addiction, what isn't an addiction? People don't always fit neatly into diagnostic categories. And I'm sure you've all seen this in your respective practices. You know, very rarely does anybody ever pick up the phone and call me and say, oh, yes, Tim, I'm looking for treatment for F11.20 opioid use disorder uncomplicated. So people don't always fit in diagnostic categories. They call me because they're sad. They can't break out of this sadness. They can never calm their mind. They're constantly upset. I've been trying to give up this drinking, but I just can't. So sometimes it's very difficult to identify addictive disorders. Assessments in and of themselves can be challenging, and I have met my fair share of clinicians who, basically don't feel comfortable working with addictions. Uh, Things like, well, if the patient tells me that they're struggling with something, sure, then I'll address it, but I don't go fishing for it. And I've also met my fair share of providers over the years that want absolutely nothing to do with it. And they will refer persons with substance use disorder to other avenues of treatment. And I've also unfortunately met the providers who have told patients, yes, I acknowledge you have a dual diagnosis, which of course is a substance use disorder and a co-occurring mental health disorder, but I will not treat you until you've received treatment for your substance use, which today we know can be quite detrimental to both conditions. Additionally, we also know that some persons may exaggerate symptoms in the other, while patients may also downplay or out and out deny their symptoms. Oh no, this isn't a problem. My spouse, significant other, etc. They're constantly complaining about this, but no, I don't have a problem. I can quit anytime I want. So there are many factors that result in or create challenges, if you will, for us in identifying who actually is struggling with an addictive disorder. The next slide, please. Okay, now Bill actually set the table for us. He gave us some really great information. And in the next couple of slides, I'm going to sort of scope out from the neuronal level to brain circuitry. And again, uh, each of the three areas that I'm going to talk about has its own relation to addictive disorders and to the maintenance of the addictive disorder. So we're moving out now from the individual cellular level to the various regions of the brain that are very involved in addiction. The next slide, please. We're going to begin with our prefrontal cortex, and this is the very front of the brain. Actually, if we were to look immediately up from our eyes, we would be heading in the correct direction of our prefrontal cortices. And the overall job of the prefrontal cortex is what we call executive functioning. And that's basically the administrator of the brain. It helps us to prioritize things. We come up with decisions after weighing various types of evidence or competing ideas, and we eventually arrive at something that a course of action that we want to take. That's complements of our prefrontal cortex. It helps us also to regulate actions. Impulses, hopefully, and certainly emotions. But unfortunately, in the addicted state, we find that the prefrontal cortex does not go unopposed in its activity. Next slide, please. And for the sake of, I talk about the prefrontal cortex as a whole, we have various ways of delineating it, neuroanatomical designations, functional designations. For the sake of tonight, we're going to talk about three different areas. Our dorsal medial prefrontal cortex, which is the seat of whether or not we're going to engage in a course of action or not engage in a course of action. Our ventral medial prefrontal cortex is very important in terms of the delineation between self and other. And our orbital frontal cortex is very much the seat of upward and downward thinking. Now, this, you may have heard upward downward thinking. You may have heard it as the upward thinking as from the top down. And this type of thinking involves things like cognitive modulation, predicting reward. So for instance, I'm going to go back to Bill's chocolate bar example. If I know that eating that chocolate bar is going to taste good, hey, I'm able to predict the reward that I will get from that. However, it also gives me the ability to control that behavior because as the totality of my prefrontal cortex is weighing the results of that decision, yeah, Tim, but whenever you eat chocolate, you get nightmares. Or, hey, what happened to that 10 pounds you were trying to lose? So again, top-down thinking is very much involved with some of those functions. Now, our downward thinking, this is also referred to as bottom up. This is responsible for receiving sensory input and then, of course, weighing that reward value. And it also has a great deal to do with emotions. The prefrontal cortex remained, as Bill had mentioned, a lot of the brain we didn't fully understand, but we really came to appreciate the role of the prefrontal cortex in the next slide from something that happened in the 1800s to a very unfortunate engineer named Phineas Gage. I'm positive everybody remembers this from this instance from grad school. He worked for the Hudson River Railroad. He was a construction foreman for the Hudson River Railroad. And on one fateful day in September of 1948, while preparing to blast rock, his tamping rod accidentally hit the stone and ignited the uh, gunpowder, and it blew the rod directly through the left side of his face, behind the cheekbone, up through the eye, of course, permanently damaging, destroying the eye, and the tamping rod went directly through his head. And here is renditions to the left. That is Mr. Gage. And everybody was surprised. He just he survived it. They were dumbfounded after that. And but there was an interesting thing about Mr. Gage. He was different. Now, Mr. Gage, you know, some things some stories become apocryphal. They said that he became a drunkard and swearing and just a detestable gentleman. His physicians, of course, who worked with him and people who knew him said, well, that wasn't exactly true, but Phineas was no longer Phineas. His ability to make decisions had become impaired. His ability to modulate impulsive thoughts and acts certainly was impaired. And of course, now as we're able to see, you know, the areas of the brain that were damaged, perhaps Phineas Gage represents one of the earliest examples of a lesion study we have, because again, his physicians were very interested. One, how did you live after this? Don't forget it was the mid 1800s. And two, well, what happens when this area of the brain is damaged? Next slide, please. Some other areas that we're going to talk about are the extended amygdala. And I'm not going to get too deep into this, but yes, they are comprised of the neurons that Bill had described several slides ago. And our extended amygdala, it doesn't work only by itself. It has subregions found under the basal ganglia of the brain. And the job collectively is to regulate our reactions to stress. And this also includes things like our fight or flight system. Everybody is familiar with that. And our emotions, such as irritability, anxiety, etc. The extended amygdala regions also interact with other brain areas, such as the hypothalamus and our pituitary, aka the master gland, which sits at the base of the brain. The hypothalamus, of course, also in conjunction with our pituitary, signals and sends messages to our adrenal glands, which of course sit on top of each kidney. And as you recall, during times of stress, our hypothalamic pituitary adrenal axis is activated, and there is the eventual liberation of cortisol, the stress hormone. And that's going to become important as we dig a little deeper into how addiction creates dysphoria in the person during the withdrawal states. If we can forward 2 slides, actually, we're going to dig just a little bit deeper into some of the terminology that's going to inform our discussion of addiction, because as Bill set up for us, language changes from version of DSM to DSM. And if we focus on some of the important terms that are related overall to how these brain circuits interact with one another, we'll have a better understanding of what's going on in the cycle of addiction. Impulsivity. When we're talking about impulsivity in relation to substance use disorder, we're talking about the person's inability to resist urges or prevent stopping ourselves from attempting to gratify ourselves in the instance. Additionally, it could also represent non-reflective or unreflective decision making. And taken as a whole, impulsivity refers to our activity without foresight, or even thinking about or without regard to the consequences of the decision that we are about to make. Many times you will see the impulsive person will get the immediate reward from what they have said or done over the contemplation of the long-term rewards. Positive and negative reinforcement, these are opposite processes that you learned about probably back in undergrad. Your positive reinforcement is the process through which when a stimulus is accompanied by a nice response, we want to do it over again. And a negative reinforcer is the situation in which there's a removal the removal of a stimulus, like a negative feeling or emotion, is associated with something. And in this case, unfortunately, the taking of a particular substance. Next slide, please. Compulsivity. And, interestingly, this term, everybody is familiar with OCD. You're going to find a lot of similarities here. The person who has a compulsive behavior or demonstrates compulsivity, they engage in repetitive behaviors despite the fact that there are adverse consequences. And of course, they have to repeat the behavior despite the fact that it might be inappropriate to a situation. And we've all seen people who suffer from compulsions. They'll often tell you, like, I don't know why I'm doing this. I know that this is deleterious to me. This is harmful to me. I should not be doing this. But nonetheless, they are emotionally compelled to perform whatever it is, because in the completion of the compulsion, in the exercise of the compulsion, tension, stress, anxiety is released. Now, with that background in mind, we're going to advance to the next slide, and we are going to begin the cycle of addiction by talking about the binge intoxication stage. And if we go to the next slide, it begins with the basal ganglia. So this is the stage in which the person consumes the substance of choice. And yes, in the beginning, it felt good. It was, something that perhaps it was the forbidden fruit. Maybe it was something I was very much, interested in trying. Somebody talked me into it. I tried it. But I continued doing it for whatever reason. And this stage is very much involving our basal ganglia and a couple very important regions below the basal ganglia, the nucleus accumbens, which Bill already talked about, and our dorsal striatum, which is another important area. The dorsal striatum, what is this basically? It's a nucleus, which is that picture that Bill showed you of those cells. This is a group of those cell bodies all pulled together, and the importance of the dorsal striatum is that they play a role in habit formation. The nucleus accumbens, that is that little picture of the neuron that Bill had shown. There are a group of those together, and they play a role in processing our motivation and whether or not something is rewarding or something is pleasurable. And unfortunately, these two areas are affected by substances in a variety of ways. Next slide, please. So what we see in the reward circuitry, which we've come to refer to it as in the basal ganglia, the nucleus accumbens, we see that there are a variety of things that are at work here. There's dopamine, there are our naturally occurring opioids. They all play some type of role in the rewarding effects of alcohol and other substances. And interestingly, the ability of stimuli or cues, as Bill pointed earlier, are often enough to stimulate or trigger a craving or a seeking of the substance. Now, with repeated pairings of substances, and you fill in the blank, whatever substance, alcohol, opioids, etc., what we eventually see begin to happen here is the activation of that habit circuitry in the dorsal striatum. It begins to become hardwired so that even though I know I shouldn't have that cigarette, I know I shouldn't have that drink, I can't help it. I need to have it because now I have formed a habit. And unfortunately, that habit turns into the compulsion. Next slide, please. So again, it's important to know this aspect of it because when we understand the relationship between the reward and the habit neurocircuitry, you can appreciate why cravings and compulsive substance seeking begins to occur in persons with substance use disorder. And once again, you don't have to tell the person. They'll tell you, yeah, I know I probably should, give up this drinking. I know that, these cigarettes are not good for me, but I can't help it. Next slide, please. We're now going to move from the binge intoxication stage in the next slides into the withdrawal negative affect stage. So what's happened at this point is the person has stopped taking the substance, whatever it was. I haven't had a drink in a while. I haven't used opioids in a certain time frame. And now in the next slide, we see some uncomfortable things begin happening. So in this stage, we start seeing internal cues, feelings, affects, both physical and psychological, that are going to set the person up for the next binge binge intoxication stage. Now, what we see is the person begins experiencing withdrawal symptoms, and yes, there are negative emotions, and depending on the substance, can potentially be life-threatening withdrawal symptoms. Alcohol withdrawal, for instance, one of the big things that we worry about, seizures. Seizures can become protracted. Some people have died from alcohol withdrawal seizures. It is something that happens. So again, it is this negative affective state that will, again, make that person begin seeking once again. Many times, and maybe you've heard this in your own patients, they have told you things like, it stopped being fun for me. The opioids, that I don't get the pleasure from them anymore, but if I don't keep taking them, I get dope sick. And what they're referring to is the actual physical withdrawal that they are experiencing in the withdrawal negative affect stage that is quite unpleasant. Additionally, I've met many patients that have come out of inpatient treatment for substance use disorders with a variety of new psychiatric diagnoses that they never had going in. And many times persons who are withdrawing will tell you that they are extremely depressed. Of course they are. It is a negative affective state. Unfortunately, along the way, some of them get diagnoses of major depressive disorder, but that's another seminar for another night. Next slide, please. Okay, so again, symptoms of withdrawal, we know that they occur with virtually every addictive substance. And even though people argue marijuana, yes, no, marijuana does have a withdrawal symptom, does have withdrawal symptoms as well. Now, how bad the withdrawal is going to be, its intensity, its duration, etc., very much related on many levels. What was the type of substance? What was the severity of the use, frequency, etc.? Some persons will have relatively light withdrawals. Other people will, as I've already mentioned, have life-threatening withdrawals. And again, the negative feelings, the negative affects come from two different sources. First, again, there is a diminished activation in that reward circuitry of your basal ganglia. But the second is that activation through the hypothalamic pituitary adrenal axis that complements of the extended amygdala, the individual is experiencing actual physiologic stress through the activation of HPA axis. Next slide, please. So over the long term, when persons continue to use substances, basically they will eventually cause a dysfunction of the dopaminergic reward system in the brain. Basically, it begins to, for lack of a better term, and to keep it conceptually easy to think about as burning out. Because again, as Bill pointed out earlier, many of these substances they don't give the same level of pleasure as the naturally occurring pleasure circuitry of the brain. If somebody says tonight, "Hey, Tim, that was a great seminar. You actually sounded like you knew what you were talking about," I'm going to smile. That's a little dopamine burst for me. If somebody, after you're finished with the seminar tonight, you go out for a really good meal, yes, you are going to get a little dopamine burst from that. Those are naturally occurring dopaminergic activations. But in substance use, these dopamine bursts are much greater than what one would expect to be naturally occurring. And of course, the more activation there is, the more stress there is placed on that neuronal circuitry, which begins to result in some cell death, which means I need to take more and more and more in order to get the same feeling. And I think everyone's heard of the term perhaps chasing the dragon. I'm going to continue trying to get back to those first times in which I experienced such a tremendous high from the substance. Interestingly, brain imaging studies through a variety of imaging techniques have consistently shown long-lasting impact in dopamine, a specific type of dopamine. We have 5 different types of dopamine receptors. Our D2 receptors in particular, however, seem to be related to the rewarding things that happen both naturally and via substances. And individuals who have used substances over a long period of time typically have less responsive D2 receptors when compared to persons that do not have a substance use disorder. And again, this is seen in persons as they're withdrawing from a variety of substances. And interestingly, other studies have shown that if you give a person a stimulant for, perhaps ADHD, what have you, if they already had a problem with addiction, you're going to see less of a dopamine release than if that same dose of stimulant was given to a person who never had an addiction. So, in some studies, dopaminergic circuitry, especially in persons with stimulant use disorders, rather, dopaminergic circuitry has been shown to be impaired for several years following cessation of the substance use. Next slide, please. Okay, so what we're basically seeing overall, the brain circuitry involving dopamine is experiencing overall reduced sensitivity. And this is an overall problem for the person in recovery because now the naturally stimulating behaviors don't have the same salience that they did before the addictive disorder. So things that we naturally should respond well to, the natural reinforcers, food, sex, being told that you did a great job, some type of an achievement, they just no longer have that same level of affective salience as they did before the substance use disorder, because these natural reinforcers are also contingent on the functioning of normal dopaminergic circuitry. Next slide, please. All right, so this again will explain why persons with substance use disorders never really get the same level of satisfaction or pleasure in activities that they once had. And again, in general, as you see that there's a loss of reward sensitivity, this could be one of the other factors that are responsible for escalation of substance use in the person with the addictive disorder. Next slide, please. In this final section, we're going to now talk about that's what happens in the withdrawal and the negative affect. We're going to talk briefly about what happens in the preoccupation and anticipation stage. In the next slide, you're going to see a line of interrelated things that occur. So in this stage, you see the person starts looking for the substance again. There has been a period of abstinence. I am not feeling well. I am feeling psychologically down, and perhaps I'm having some physiologic withdrawal as well. And again, depending on what the substance is, how severe my substance use disorder is, the time between when I last used and when I started experiencing these negative withdrawal symptoms could be quite varied. In this stage, I start becoming preoccupied with using the substance again, which again we continue to call a craving. And cravings are hard to really measure in people. And we also know that cravings are not necessarily linked to relapse. Some people will tell you, I'm having tremendous, horrible cravings, but they don't relapse. Other individuals may experience what they said was, I don't understand why I relapsed. The craving wasn't all that bad. So again, this is involving our prefrontal cortex. Next slide, please. And I'm going to wrap up my section here by pointing out that it is, again, that prefrontal cortex responsible for all of these thoughts and emotions. It is the prefrontal cortex that needs to be capable of weathering these very negative affects, the activation of the hypothalamic pituitary adrenal axis, etc. And the executive function needs to be powerful enough to override that much more that very potent desire to use the substance, which will make that negative affect, be it both psychological and physical, go away. And Bill already mentioned this earlier. This is why in AA they do talk about, we talked about associative cues. This is why you should not be, if you are struggling with an alcohol use disorder, you are in recovery. This is probably why you should not be going to that party where alcohol is being served. Because again, it increases the likelihood of my executive function not being sufficiently powerful, my prefrontal cortex not being able to speak to some of these lower brain function, some of these lower brain regions and say, okay, I'm not going to do it. I will sit here and watch everybody else having a good time, but I won't, which again is a challenge. Okay, and that's the conclusion of this section. I'm going to turn it back over to Bill.
Okay, so we're going to talk now very quickly about the progression of addiction. And so what ends up happening as the addiction becomes more chronic, more severe, the person's behavior creates a disturbed environment for those who live with him. So we've always known that addiction is really a family disease because as addiction progresses, the addict becomes more preoccupied with the drug. And so they're more interested in maintaining a supply, covering it up, despairing about having to get high again. And though the family is loved, they take a back seat. And so during periods of abstinence, the addict feels lonely and isolated because he no longer has meaningful relationships with people. He's burnt his bridges, right? These feelings are compounded by additional feelings of shame, fear, guilt. And to survive, the addict denies these feelings and places the blame for them on others, their family, friends, and coworkers. So we say that the major defense mechanisms used by people with addiction is denial and projection. And so we always see the family being drawn in. Since the person with addiction cannot bear to feel, he cannot tolerate family members expressing honest feelings. And so as the addicted person loses control over his own life, he demands and gains control over the family's life. And then therefore the family has learned to plan its life around the addiction. And so when we do our initial assessment, the main purpose is to determine the need for medication and medical management. And so this includes an evaluation of predicted withdrawal, the severity of that, any medical comorbidity, and any psychiatric comorbidity, because this confounds treatment. So people with medical problems, with psychiatric problems, this interferes with the treatment of addiction. And so as a rule, persons with addictive disorders often do not receive regular health care. So when you're working with this population, generally, they're not in a good state of health. Medical care for acute and chronic conditions can be fragmented and inefficient. So the diabetic, the asthmatic, the cardiac problems, they're really not taking care of themselves. They miss opportunities to receive preventive health care like vaccines. And in addition to direct effects of intoxication, overdose, and withdrawal, the abused substances can affect every body system. So the drugs themselves don't work just on the brain, they work on other body organs. And of course, alcohol is being one of the worst. So before we begin any type of psychological treatment, we really need to obtain a detailed drug and alcohol history, including their current and recent use history. If you can, get a urine drug screen or send them to have one done, and determine priority of data collection based on their immediate physical needs. They may need to be referred to an inpatient addiction treatment or an inpatient hospital. Objective and subjective data regarding current health status is important for you to collect. And you all know all this stuff, past medical, psychiatric, addiction history. You should review every body system, specifically what kind of complaints do they have, any history of psychiatric systems or symptoms, and their substance use disorder history. And if you can, get family history, current family status, and then definitely a mental status. And in addiction treatment, we put a lot of emphasis on spiritual health. This is growing in psychiatric and medical circles also. It has to do with the concept of higher power. And more specifically, if you're not really aware of the whole concept of higher power, their source of hope and strength. We got to get our patients to have some level of hope and strength. We want to understand their personal, developmental, and social history, work and school adjustment, relationships are a big one, and then how do they cope and adapt? Current use of addictive substances. So we want to know what they're using, how often, for how long, and what route. So obviously, withdrawal is going to be more severe if they're using the IV route for their drugs. And when they stop using, withdrawal will be severe. What effects have they had in the past in using the substance? What behaviors? What are the consequences that they're suffering? Is there, when you see them, the presence of intoxication, withdrawal, or tolerance? A presence or absence of cognitive deficits? And then, of course, always we have to do suicide risk assessment, including what's preventing them from suicide or the protective factors. Stages of change are a big thing in addiction treatment, and you should very much be familiar with them and the stages: pre-contemplation, contemplation, preparation, action, maintenance, and then relapse, which is considered a part of addiction treatment. So problems associated with addiction, you should all, again, be familiar with these. The physiological problems certainly should come to light when you meet with your patient. So altered levels of central nervous system responsiveness. So are they hyperactive? Are they sedated? Do they have seizures or a history of seizures? Any altered psychomotor patterns, their GI dysfunctions, heart, liver, respiratory system. Pain management is always a big issue with people that get started on opiates. And of course, there's always an increased risk of sexually transmitted infections. The psychological problems that we see with this population: impulse discontrol, unmanageable feeling states, such as mood symptoms, shame, guilt, anger, hopelessness, helplessness, aggressiveness we see. Disruption in self-concept is a big one. And in psychoanalytic thought, a lot of work is done in that particular area, and excessive use of defense mechanisms, which again is very psychoanalytic. Family problems, we should always be familiar with how the family is reacting in the addiction system, the disruption, the crises, role model failures, marital infidelity, enabling behaviors of family members is always a big problem. Family members think they're helping when they're really enabling, which is helping maintain the addiction, not helping to decrease it. And unfortunately, the children assume the role of parents, and the level of instability is very great and pretty much universal. Social and community problems that we see, interpersonal relationships, obviously, they're burning bridges all the time, altered productivity at work, inability to behave, deterioration in social life, criminal activity and violence, the risk factors of poverty, racism, unemployment, and homelessness are also a big problem in this population. And then in the workplace, a lot of times I find in my practice that it is the employer that refers the patient to me because of workplace problems. So maladaptive coping strategies, absenteeism, decreased morale, accidents on the job, inconsistent behavior at work, and deterioration in work performance. And then, of course, we have legal problems. A lot of times DUIs are what bring people into treatment, but we see prostitution, arrests, criminal activity, illegal drug sales, domestic violence. These folks are often branded as being antisocial personality. But the DSM has been very sensitive to that, and they say that any criminal, arresting, or illegal behaviors associated with getting the drug, using the drug, or withdrawing from the drug, you cannot use antisocial personality. They have a code called antisocial behavior. And so it just covers behaviors associated with drug use or other toxins or things like that. And of course, we have the spiritual problems, disruption in spiritual connectedness, diminished purpose in life, feelings of meaninglessness, loss of control over self. These are all things that long-term therapy needs to address in the person. Cognitive problems we see with these folks all the time. I'm not going to read any of those, but you see them when they come into you, and that should be the first thing that you should be ruling out. Is it a substance? A lot of these cognitive problems that come in will say, I think I have ADD. I think I have ADHD. When really it may be cognitive problems associated with either a neurocognitive problem or a substance use problem. And when you're evaluating care, you want to document their responses to interventions. If your interventions aren't working, you got to try something else or refer them to a higher level of care. Examine the patient's progress towards attainment of outcomes. So you need to have treatment goals for this population. Involve the patient. You need to involve significant others, other healthcare providers, specifically supervision in working with this population, because the negative countertransference that occurs is tremendous. And ensure that evaluation is an ongoing process. It's not a one-time deal, and then you go into therapy and don't worry about continued evaluating the patient. You got to do that. As far as relapse prevention, there are factors that we know that are associated with poor outcome. So if they don't accept that they have an addiction, if they have no desire to change, if there's a higher severity of the disorders that they have, if they don't adhere to their medications or other treatments, if they lack supports and they have poor coping skills, all these things should be targets for you to figure out the prognosis going forward with these patients. And then we have factors related to affective or mood states, which you're all familiar with. If you still see a lot of anger, anxiety, depression, that needs to be addressed. Um, Behavioral variables, so poor coping, stress management, the cognitive variables that we see, namely lack of awareness or acceptance. We got to figure out how we're going to deal with that. We need to get family supports involved as best we can with that. And then, the environmental variables, they're always there. I always want to pull out my hair when the patient comes in that tells me they're severe alcoholic, but they're a bartender. It's the only thing they can do, and it's the only way they can make money. But what are we supposed to do? Tell them they can't do that? So we have to bring reality in and figure out how we're going to deal with that in a creative way. So how available are the substances? What types of social pressures do they have? What kind of support network do they have? If they're homeless, that's already a problem in and of itself, poverty, and then stress related to major life changes. And then lifestyle factors and healthcare practices that occur. So smoking in itself has been found, there's been multiple studies that if you can get them to stop smoking while they're in treatment for other addictions, your success rate goes up tremendously. That has been replicated, that study, getting them to stop smoking while they're in treatment for another addiction, and their outcomes are positive. There's always personal vulnerability. We're always looking for resilience in our patients, and that is an important variable towards a good prognosis. And of course, there are physiological variables. There are post-acute withdrawal symptoms, there are cravings, and of course, physical pain and illness. And then there's psychiatric and psychological variables. What's going on with personality, with their motivation, with their other psychiatric disorders? Are they being managed properly? And of course, their relationship issues. Have they lost their significant relationships? Have they burnt those bridges? What kind of family discord, marital discord is there that you have to worry about? Spiritual variables, and of course, treatment participation. If they're not coming to treatment, how can you expect to help them? If they're getting the wrong medications, how can that be helpful? If they're getting inappropriate advice, if they're not getting access to proper treatment, these are all important things that you have to keep in mind. And with that, we're going to finish up with Tim and his approaches to treatment, both psychopharmacologically and psychotherapy.
Thanks, Bill. If we could flop up to the next slide. The history of drug use treatment, I'm not going to get too deeply in the woods with, but what we do probably know is that substance use has occurred for most of human history. It's even mentioned in the Bible. It was in 1784 that Benjamin Rush, an early physician, came to believe that alcohol is a disease and it should be treated, and not as a moral failing as was believed up to that point. His work endeavored to teach the general population about the hazards of alcohol, but during the 18th and 19th centuries, it was known that alcohol was actually becoming quite a significant problem. Unfortunately, whether he knew it or not, his work was launching the temperance movement, which would eventually culminate in prohibition. I said several slides ago that the forbidden fruit is always the sweetest. Of course, there was a lot of social unrest, ineffectiveness of the prohibition, and of course, the rise of organized crime, which would eventually see the repeal of prohibition in 1933. Next slide, please. Early approaches to treating substance use disorder included removing the quote-unquote addict from society and placing them in places such as this. This is actually an old sketch of the inebriate asylum in Binghamton, New York, which was founded in the 1860s. Interestingly, I did my geriatric clerkship there, but it was the first medically monitored considered addiction treatment center in the United States and widely considered the first rehab for persons with alcohol use disorder. Next slide, please. Similar homes would crop up across America throughout the 1800s and continued into the 20th century. Some other fun historic elements to this. In the 1880s, Freud started recommending cocaine to treat alcoholism, as well as what they termed morphinism, which of course was morphine addiction. And everybody, I'm sure, you know that he called it the miracle drug. He used to mail some of it to his then fiance, encouraging her to use it. And he actually treated Ernest von Marxwell with for his morphinism with cocaine. And here's the crazy thing, it worked, but poor Ernest had a different kind of addiction after his treatment was over. So again, Freud wasn't the only one who tried it. Many American physicians used cocaine to treat morphine addiction, and yes, it did work. The only problem is the person was no longer addicted to morphine. Now they're addicted to cocaine. So next slide, please. And actually, I can go on. I could talk about this for hours. I won't. If anybody here is interested in learning more about the history of addiction treatment in America, the text by William White, Slaying the Dragon, now in its second edition, you can pick it up for a song on eBay. Definitely, I would encourage you to consider that. Next slide, please. So in terms of treatment, Bill already talked about motivation to change. This is important because when patients call me to request initiating services, one of my first questions is why now and what's the motivation behind it? I have met many therapists who have said, well, you know, if they tell me that, you know, somebody else told them, you know, you have to get treatment or you're finished, they won't work with the person. I believe in just giving it a shot. Why not? Perhaps I can help stimulate internal motivation. Who knows? But next slide, please. Motivation is important overall. Medications, they've definitely come a long way in terms of opioid use disorder. We now have Vivitrol. We have, of course, methadone, buprenorphine, the so-called MAT. By the way, I want to point out that medications are not without their detractors. I do medication-assisted treatment with Suboxone in an outpatient clinic 2 mornings a week, and some people have asserted that I am a legal drug dealer. But P.S., the individual is receiving the opioid, the combination that they receive prevents it from being diverted, smoked, injected, etc. And the person is now free to pursue life, thus obviating the other DSM-5-TR criteria that establishes an opioid use disorder. For alcohol, yes, we could use naltrexone there. We have various other drugs, Campril, Antabuse. When it comes to nicotine, good old-fashioned Wellbutrin seems to help. Newer medication, Chantix. Some people work, some people it doesn't. Unfortunately, for cocaine, we don't have a great deal. Cocaine and methamphetamine, some practitioners will try buprenorphine with limited success. They've attempted to make cocaine vaccines, which, believe it or not, actually work in rodent models, but with some exceptions, rodents aren't humans, so it doesn't really translate into working in people. So again, we're kind of limited in some areas with what we can treat with medications. Next slide, please. All right, so our psychotherapy approaches. Next slide. We find the big one, the one that started it all, Alcoholics Anonymous. So the assertion by the AA community is that the program works if you work it, and research tells us maybe. Research is very limited in the AA community, and the results are very mixed. People who have gone through the AA program and have achieved and maintained abstinence from from alcohol, or NA for Narcotics Anonymous for opioids, etc. If they've gone through it and it worked for them, they swear by it. Other people say it did absolutely nothing to help them. Next slide, please. We also find various research in which they've looked at all of the treatments for alcohol and compared it to AA. The 2002 study by Hester and Miller ranked it 38 out of 48 treatments. Dodds and Dodds in 2014 analyzed the success rates and claimed that they found it to be between 5 to 8%. And again, a problem with any of this kind of research, I want to just remind everybody when we're talking about statistics, there are always limitations to it. And by the way, people who participate in surveys in and of themselves are by definition different from those who decline to do so. So again, we have to be very cautious. If a person I get asked all the time, will you work with somebody in AA? And my answer is most definitely. Sometimes we need to do multiple treatment approaches. Patients have asked, well, do I have to be in AA when we work together? And my answer is no, you don't have to be. So again, everybody will come to do different things, of course, with treatment. Next slide, please. Self-help groups, many people do not take to the religious/spiritual overtones of AA. So there are alternatives, self-management and recovery training or SMART groups, secular organizations for sobriety, aka SOS. Many women found AA was not exactly to their liking, so the Women for Sobriety programs have cropped up. Moderation management for individuals who do not wish to quit, but instead want to alter their drinking patterns. I know very little of LifeRing, but I do know that there are many minority group oriented recovery programs out there, each of course boasting success. So again, things you should be familiar with in terms of treatments. Next slide, please. We also find motivational interviewing. Critics of motivational interviewing say that it's nothing more than coercion, but it does build on a long tradition of treatment approaches, specifically Carl Rogers' humanistic theories about the individual's capacity to exercise choice and change in an attempt to achieve self-actualization. When properly done, motivational interviewing is about forming a partnership or an alliance with the patient and trying to help stimulate self-motivational statements, which hopefully will transform into change. Next slide, please. Alternate therapies are out there. There is some research on acupuncture for various health conditions, but when it comes to addiction, primarily anecdotal evidence. And if it worked for somebody, fine, it worked. Do it. There, of course, computers are out there, and more VR stuff is happening. So virtual reality in which the client is able in a safe setting to practice situation-specific skills, i.e. I'm at a birthday party and somebody breaks out the liquor. How will I handle that situation? Next slide, please. Yoga, meditation, again, there is research out there showing it's promising, but much more research is needed to determine efficacy overall. It does seem to help, however, with relaxation, and there have been some limited studies suggesting that it can help reduce cravings. Next slide, please. Next, of course, voucher-based reinforcement. Anybody here who has ever worked on inpatient substance use treatment may be familiar with this. It involves giving something of value, points, vouchers, etc., in which the person can, use that credit for certain privileges, or in certain cases, they can purchase things in hospital or organizations, gift shop, or even local stores. It seems to have some significant efficacy, some initial significant findings with efficacy in treatment of stimulant use disorders, specifically cocaine and methamphetamine. And of course, the person's abstinence from the substance is measured through urine toxicology screens. Next slide, please. Additionally, there is treatment, other therapies as usual. Bill mentioned detoxification. This, of course, is removing the toxins of the substance from the body, and detoxification should be medically supervised because it's not only safe, but I argue a humane way to withdraw from the substance. Of course, a variety of treatments are out there. Everyone's heard CBT, REBT, the manualized approach is 12-step facilitation. Of course, there are various groups, whether they be peer groups, professional groups. Bill already alluded to the need for family and couple therapy. And of course, the combination of medications, individual and group therapy seem to show excellent promise. Next slide, please. So what is missing from the approaches I've talked about? Psychoanalysis to our next slide. Unfortunately, for various reasons, it was the earliest of all of the approaches that ever considered addiction. However, over the course of psychoanalysis literature, we see interest in it has waxed and waned. The primary belief many years ago was that the quote unquote addict, specifically referring at the time in much of the literature to the alcoholic, was incapable of forming the transference to the therapist. But again, missing from that early explanation is also the countertransference from the therapist back to the patient, which many times is quite negative. And of course, as we know, patients can pick up on that. Next slide, please. So again, the purpose of this webinar tonight, in addition to giving an overview, is to really make a case for the need to additionally delve deeper into what the rich tradition of psychoanalysis and what many of the pioneers did for addiction, and of course to take their work even further. There is a need for addictions professionals in the mental health area to have knowledge of addictions. Next slide, please. Why? Because of the overall success of treatment thus far. We know about approximately 2/3 of persons with alcohol and drug issues will relapse within 1 year of treatment. Now, two different camps argue here. I'm in the camp that argues that it is a part of recovery, and what we're supposed to do after the relapse is to learn what worked, what didn't work, what failed, what didn't we do, what could we have done, etc. But then there's a whole other camp that says, no, you're being too forgiving. It means the treatment wasn't effective. But quite sad is my last point here. Among people who have met the lifetime criteria for substance use disorder, less than 45% of them have achieved remission. Next slide, please. As a result of this, we need to do something. In the 2023, again, back to the NSDUH, 20.4 million Americans are suffering with both mental health disorders and co-occurring substance use disorders. And unfortunately, about 40% of all hospital admissions are either directly or indirectly related to alcohol misuse. Alcohol affects, we talk about the brain, sure, fine. There is not a system in the body that alcohol is not impacting. Again, substance use disorders are a major impact in many psychiatric hospitalizations. And not only the 2010 study I cite here, but a more recent 2020 study by Penn State confirmed that many people who die by suicide typically had an alcohol use or misuse disorder. And of course, from substance use across the gulf of a lifetime, we see severe neurologic damage that can last perhaps for the rest of the person's life. Next slide, please. All right, so why should psychoanalysts be concerned? Treatments left to the others have been lackluster, ladies and gentlemen, and it is worse for dual diagnosis. The available treatment, sure, might help some, but not others. And I quote from a patient who I actually quoted in my dissertation. He basically told me, look, Tim, I've been through it all many times. I've been through detox, inpatient hospitalization, intensive outpatient, partial hospitalization, group therapy, AA, individual treatment, and then I relapse, or I wash, rinse, and repeat. So the questions that we're all faced with tonight, especially with analysts here in the room, is can psychoanalysis be the answer to these treatment failures? What impact can we have overall on healthcare costs? Because that 40% of hospitalizations is significant. And with the work that we have the potential to extend as part of that long legacy of psychoanalysis, can we become the gold standard for treatment of substance use disorders? And I don't have the answer to this. Instead, I hope to stimulate those thoughts in the imagination of each of you, because I certainly hope to be part of that. Next slide, please, which I believe is next steps. In-depth exploration of the history of psychoanalytic treatment. That is what we're going to be doing in the class in the fall. What has psychoanalysis contributed? You're all going to be surprised because the answer is plenty. And what about current psychoanalytic contributions? What's happening out there? But most importantly, the future that's up to us collectively. What can we contribute to perhaps one of the largest societal problems out there? And I think my next is my references, and that's it. Thank you.
Okay, so we have about 10 minutes for any questions.
We have a number of questions in the chat room, which I can sort of go down the list for you
Okay,
both.
sure.
First question, do addictive behaviors like gambling stimulate the same area in the brain, the mesolythic pathway?
Absolutely, they do. So that's the short answer, yes.
The old saying, "All roads lead to Rome." Well, it seems as though all addictive roads lead to the VTA, ventral tegmental area, and the nucleus accumbens.
There was a follow-up to that that just says amphetamine salts question mark, and I'm not exactly sure what Nick had in mind with that follow-up.
That was actually answered in the slide. Yes, they do.
Okay. Next question, is there any difference between nicotine that is taken in through smoking versus the smokeless nicotine pouches such as Zyn?
Well, yes, there is. The the issue has to, well, psychopharmacologically, there is a difference, but both the patches that contain nicotine, again, hit the nicotinic or the acetylcholine receptors the same way. From a neuroscience point of view, it works the same way. We're stimulating the acetylcholine receptors with the patches, transdermally, and causing the same effect, but without the other chemicals that are in cigarettes. See, that's the difference. So that's kind of like, so the nicotine patches work following the same rules as substitution therapy, like methadone and buprenorphine work for the opiate addicted person. So we're substituting the substance, but it's cleaner and it works better, but it hits the same receptors. So we call that substitution therapy. We're substituting the mechanism, using the same mechanism of action to replace the drug of abuse.
Okay, next question. What are your policies regarding patients coming to their session intoxicated or high? Is there a request to postpone use until after the session? Discussions of efficacy of treatment when coming to session under the influence? Question mark.
Well, our clinic, I don't think has a policy. I think that's individual. I can tell you what my policy is, and Tim can tell you what his is. The belief is that people that are under the influence don't have the capacity to learn new things. So why do therapy with them? They should be sent home, but they shouldn't be allowed to use their own means of transportation like a car. So if they come in intoxicated, we basically are, at least in Pennsylvania, are required to take their keys away from them. And if they refuse, to call the police. I don't know whether other municipalities have similar rules, but I will not treat somebody that comes into the office intoxicated because they can't retain what they've learned. They are very much muted. I don't know, Tim, if you have a different philosophy there.
I basically do, for me it depends on how intoxicated they are. I had one person who and I'm positive he had the beer in the parking lot before he came in because his previous therapist had thrown him out of her practice for coming in smelling like beer. And he thought I was going to do the same thing. And he clearly didn't have the same level. Clearly he had something, but he did not have the same level. And yes, I said, you are not you are not driving home because legally I will have to alert law enforcement. So he did actually wind up calling his daughter, but when he saw that I didn't have the same reaction, get thee out, that was the last time he ever did it. So, it all is going to boil down to you, your own personal philosophy, and again, as Bill pointed out, safety is primary. How did you get here today? Well, I drove, and clearly the person can't walk a straight line. That obviously is a public health disaster waiting to happen, and you do have to act appropriately. But I do see how impaired the individual is. Interestingly, sometimes I've had persons who are impaired, are under the influence, tell me things that they otherwise wouldn't have said. Because don't forget, in the intoxicated state, the inhibitions are sent on vacation. And I've had patients say some things that they had never actually said before, which of course, it's all grist for the mill, to quote Wally.
Okay, next question. How do you balance getting family involved with the risk of enabling, complicated by emerging adulthood?
Well, that's the whole purpose of bringing them in and working with them and explaining. I mean, we also have a role in education, in addition to therapeutics. And so education of family members is an important part, at least for me, in telling them what behaviors do they engage in that are enabling and what are they doing to help them get clean. So, and then also being a part of the solution
Mhm,
is the big part. And we have to get them to learn that there has to be consequences
mhm,
to the addicted person's actions rather than acceptance. That's another big part in family education that most families don't really understand. That's so, and I'm not saying that it's easy, it is difficult. And of course, we always need the patient's, approval to bring the family in or to contact them or whatever. But I got to tell you, more times than not, I find that the chronic user has burnt bridges and the family aren't interested in coming in. And then we got to figure out how we're going to deal with that. And that becomes a major problem in and of itself. But more than anything, if we can't get family in, we at least have to be creative in getting a support system together for that person. We cannot be the only support that the patient has in coming to see us. We see them for an hour a week or whatever it is, that you do. They need more support than that, an hour a week. So, we always have to have that in the back of our minds.
mhm.
Tim, you have anything to add to that?
No, no, that was yeah. And keep in mind also in your office that could be the place where some fences do get mended. And obviously if you aren't a marriage family therapist, if you feel that these things are a bit uncomfortable for you, that's definitely where supervision comes into play and could be quite useful to help you navigate through some of these difficult conversations.
Mhm. Okay, we have 4 questions left. It is 9, but we do have 4 more questions. The next question is, what do you think of Flores' idea that addictions are attachment disorders?
We will be talking a lot about that in our course. about attachment problems in development of the child. And there are purists that believe that that is the core to addictions. I certainly will go as far as says that may be the answer for some people, but I think the progression of addiction is more complex than just saying it's a developmental issue related to a problem with attachment.
Okay, next question. What do you think about the Gorski method for relapse prevention?
Gorski. Tim, do you have any familiarity with Gorski? I've had
So,
problems with his some of the stuff that he's done.
so here's my approach. Here's my thoughts on it. Um, there are there are various approaches to relapse prevention, and my answer is this is why you should have multiple approaches available in your armamentarium, because if one doesn't work, then what do you? Oh, sorry, I used Gorski. That was it. Well, I'm sorry, you're on your own. So I encourage everybody. Learn about different in addition to what if that doesn't work, or P.S. if it works, hey, fantastic, you nailed it. But again, we should my own personal belief is that we should have many approaches available to us, and I think back to Freud, who famously noted that we have to be able to provide the patient what they need, and if they don't need if they don't need that method at that point, then we better have something else that we can offer.
Yeah, for sure. When I started at the Drug and Alcohol Center that I worked at as clinical director, my predecessor mandated that everybody use Gorski and Yalom, and that was it. And I went in and I said, "Nat, if that works for you, use it, but you got to find other methods because that doesn't work in everybody." And if you haven't been trained in that and you're mandated to use it, that's problematic too, because it's not coming natural to you. So, we would do continuing education on different ways, different models, so that people could had a whole armamentarium, as Tim said, to work through with their individual patient.
Okay, next question. Do you consider methadone and Suboxone to be forms of sobriety? They are addictive in itself.
Well, the whole issue with any prescribed medication isn't the medication, but the management of it. So yes, those substitute methods are in and of themselves addictive, but they need to be properly managed. So there are people on methadone maintenance that are doing very well and are not diverting and have gotten off of medical assistance and have productive work histories, just as there are people that aren't. And I say that they're not being managed properly. The same thing with Suboxone, buprenorphine. How is the prescriber managing it? It's not just about handing them a prescription and having them walk out and not work with them and not have them in therapy.
Mhm.
So even AA stipulates that medication-assisted treatment is a viable and acceptable method of treatment, and people that are on it are technically still in recovery. Contrary to what some of the rooms say. They say, oh, no, you're not in recovery if you're using those. I tell people, find another room to go to. You're in the wrong place, and in your support system. But to me, it's really about management. How are our patients management? And it's not just the prescriber. The therapist has a role in ensuring that management is occurring. How is that medication being properly managed? And if it's not, I think you have an obligation to call the prescriber and say, look, there's a problem here. There's diversion. They're not using their medication properly. They're misusing it. All of that. We need to catch that. So to me, it's a management issue. Tim,
And
anything you want to
yeah, and
add?
just to dovetail from that, as I pointed out, it isn't simply the use of the substance that is the substance use disorder. Again, DSM-5 is very specific about the symptoms. So when the person is using the medication as prescribed, other DSM-5 criteria obviated. They're not spending inordinately large amounts of time trying to find the substance and use it and recover from it, etc. Right now, I have approximately 100 patients in that I see throughout the month for their Suboxone, and yep, they're working. Their families going home at night, making dinner, helping kids with schoolwork. They're living their lives, and yeah, the medication aspect of it is handled. They're seeing their therapist. They're doing their recovery work that they need to do, and all's well. So, but again, you're always going to get individuals who will argue and say, absolutely not, that's not. And well, even some going back to uh, Bill's point, there are some AA groups that say, well, you're taking Prozac, you're still using. Um, Find another room.
Right.
Okay, final question. Can you comment on adults who have been taking ADHD meds since childhood and the potential effect on dopamine function?
That's, there's more and more research out there about that.
Yeah.
Initially, the belief was that 85% of children recover their norepinephrine systems to the point where they no longer need ADHD medication. So that was the rule basically throughout up until the early 2000s. And now that research has completely reversed. And now the belief is that only about 15% of children actually gain the ability to utilize norepinephrine properly, that they can come off their medication. And 85% will continue to have symptoms. The issue always is, and it's the reason why we see so often in adults poop out syndrome. These adults come in and they'll say, the medication's not working anymore. I think I need a higher dose. And then the first thing prescribers think is, I think they may be abusing this medication. When really what's happening, remember the neuroscience of how those medications work. They actually pull dopamine out of the VTA network, and we have limited supplies of dopamine, right? I mean, isn't that just intuitive that there's going to come to a point when more dopamine is being pulled out and more norepinephrine is being used, that we run out of inventory in our brain. And so that's why today we talk about drug holidays. So I tell my patients, if you don't need it, don't take it on the weekends. If you don't need it, don't take it on vacation. If you're homesick, don't take it, so that the dopamine supplies can rebuild in the brain. And we'll find that they no longer will come in and say, it's not working anymore. So that's the whole problem. It's not that, the old belief was, just like with drug abuse, people get tolerant. Well, there of the medication, there may be tolerance. Well, there may be to a point, but actually we're using up the inventory of the neurotransmitters, because the psychostimulants are actually causing more to come out and stimulate the receptors. And by definition, they don't have enough to begin with. That's why they have the problem of ADHD. They don't have enough norepi that's coming out. The dopamine is just an aside. They need the norepi, but they're using it up faster than we would normally. That's the belief today with that. So that's how the systems are being affected. And we should be aware of that and don't automatically jump to the conclusion, this is our own, by the way, negative countertransference. You must be abusing your medication because you're asking for more, or you're saying it's not working anymore, or whatever. We always just jump to, it's you're abusing it, rather than me, I'm not managing it properly because I don't understand completely neuroscience to what's going on in the brain. So we got to be real careful. And we both Tim and I intend to spend a good deal of time in our course in talking about countertransference because it's such a big issue in working with this population. And that's why so many therapists don't want to work with the population. They can't tolerate it because it reminds them of their own family members. And I tell people, when I teach addictions, I tell folks, raise your hand if you don't know anybody in your family or close friends that suffers from an addiction. And you don't see a hand go up. It is just so prevalent and it affects us. It affects our development. It affects our personalities, our character structure when we are growing up in an environment of addiction. And that creates the negative countertransference. Okay, I just stepped off of my high horse. All right, so that's it. Was that the last question, Lisa?
Yes.
Okay, sorry we kept you so long. A lot of material to cover. My rule is hopefully you learned at least one new thing in this webinar. That's
Thank,
all I ask.
I thought it
And,
was fantastic. Thank you both.
oh,
Thank you.
thank you. Thank you. So
Thank
everybody's
you.
here.
Thank you.
Thank you. It was excellent.
Thank you.
Thanks. Super.